Uh, Welcome back, everybody. You are tuned in to the Audio-Vestibular Medicine Case Discussions group. And I have my colleagues here, Dr. Mohamed Hamid and Dr. Eugen Ionescu, and I'm Gerard Gianoli. We're doing these dizzy case discussions generally the first Friday of every month. Next month, however, there is a change. We're doing the discussion on Friday, July 11th, since next first Friday will be July 4th. And I just wanted to share with everybody that uh, we are recording these, and the next how do I get this to move here? I'm trying to advance my slide, and for some reason it won't advance. I had a picture of the uh, here we go. This is our YouTube channel where we're recording all of the case discussions. And if you ever forget where the meetings will be held, if you look in the middle, we've got the meeting ID code and the passcode, which is Vertigo. And then our first two case discussions are recorded there if anybody wants to go back to look at them. So at this point, I'm going to turn it over to Eugene so he can present his case, which I think is a very cool case. All right, Eugene, it's for you.
Okay, I will share. I can, yeah, I think that it's okay. You see my screen now, everyone?
Yes.
Yes.
Thank you very much for the opportunity to present you a very nice case, I think, and I must admit that I published already this case in 2022. There was a question, I saw it on the LinkedIn. There are person which ask put it the question that the if the BPPV of the superior semicircular canal does exist, and I think that with this case report I will show that not that only exists, but he can be repetitive, like in the case of this a patient of 73 years old, female, which was referred to our department for repetitive positional vertigo, more over from which was exhibited more than 1 year, maybe two, and she was this vertigo was triggered by neck extension and rolling over in bed, and sometimes when she looked at in the superior position with the neck a little bit in extension. She had no significant odontological or neurological history, and she had not complaints of deafness, tinnitus, or pressure in the ear. She was manipulated for a superior semicircular canal, BPPV, by an experienced therapist, which nevertheless he works with us, and we know that he's very competent, and that's why he refers the patient to us. Only the habituation exercise type Brand Darrow was relieved her symptoms temporarily. As you can see here, as this was in our department, and the left, there was no spontaneous nystagmus, as you can see on the video. While in Dixal Pike, I have some problems. I will put it a little bit quicker. And the left side, Dixal Pike was negative, as you can see. And on the other side, on the right, distal pipe position, we can note the appearance of left torsional downbeating nystagmus with a maximal peak slow phase velocity of 8 degrees seconds and with a duration of 22 seconds. At the contrary, when we put the patient in the sitting up position, we did not obtain any nystagmus, reversal nystagmus. When repeating these procedures, even with mastoid vibration, every techniques during the maneuver to promote mobilization of the potential otoliths and evacuate these particles remain unsuccessful. So at this point, what do you propose, guys, as examination, further examination? I will start with Gerard. Did you the I think that everybody will perform an audiogram, even the patient didn't complain any complaints. As you see here, the audiogram shows and tympanometry. We see a slight deafness on the left side, excuse me. Tympanometry was normal, and even the stapedian reflex was normal. In this case, particular, did you see what did you perform? What did you ask for other? What were the other exams that you will ask for?
So, at least from my standpoint, seeing the low frequency conductive hearing loss with a normal tympanogram, and I don't see the reflexes on here. The reflexes,
It's
I
here,
see
it's
the reflex,
displayed here.
so they're
We put it
intact.
like that. Yes,
Yeah,
positive on the right, a little bit on the 2000 hertz.
gotcha.
At the left, they are negative, but still in this on 500, 1400, 4000 hertz was positive.
Sure. So with the normal tympanogram and intact acoustic reflexes, with the low frequency conductive loss, you have to really think about a third mobile window disorder. And one of the things I've seen in some cases with superior canal dehiscence is an anterior canal type of BPPV that isn't necessarily BPPV, but just the prolapsing of the pressure from that dehiscence. But usually, at least my experience is when that's the case, you usually get that downbeat torsional nystagmus regardless of what side you put on. In other words, you get the same response on the left as the right because the impetus for the stimulation is really more the pressure in the head rather than otoconia. Whereas in your
Yeah,
case, it looks more strictly related to
on the
that one side. Uh,
yes, on the right side.
yeah, so that kind of more implicates, a true case of canalorthiasis rather than just a depression from, the pressure from a superior canal dehiscence. Um, the other thing you mentioned, which I find more often than not, when I've seen cases with anterior canal BPPV, I usually don't see the reversal when they come up. It usually is just going down. And I think maybe it has something to do with the weaker response, or maybe it's a lower otolith load you get with anterior canal. But that's something I've also seen with the vast majority of them, no reversal.
Okay, thank you very much. So, I think that was a publication of an Australian team on this mechanism you mentioned here, Gary. When we in case of some large superior semicircular canal dehiscences, in case of a kind of attachment between dura and the canal in the dixal pike or in hanging position, head hanging position, we could observe an nystagmus, but which reverse when the patient is in standing position because the gravity works. But in this case, effectively, as I already mentioned, that was no reversal, nothing, and only on the right dixal pike position. So, and Mo, do you have something to comment?
Yeah, sure. This is very interesting, and I have two comments. One, to answer the question of people that telling you anterior canal BPPV doesn't exist. And I think it is the way they do the exam. And in doing the Dix hole pike, we have to move the eye from one side to the other to look at the vertical component. In this particular case, the vertical component is downbeating. She's lying down on the right side. So that really points straight to the left
Yeah.
superior canal. So
Yes.
that's a number one. A lot of people don't make that shift in the eye position during the Dix hole pike exam. So it is localized in the left ear. She has a left conductive hearing loss, as Jerry pointed out. And I'm surprised that she did not complain of any pathologic
Anything.
symptom. That is, it's either the audiogram is
Yeah. Yeah. Anything. Now, no pressure, no sensibility to sound, nothing.
yeah.
So,
So and the reflex is present. So it is a superior canal on the left, dehiscence, and I don't know if the vamp was done or not, but that's my
Yeah,
opinion.
there it is.
yes, yes. So we performed an standard vestibular assessment. We started with the
Okay.
VHT autometrics, and we observed that even at not so high speed velocity of the maneuver, however, we can observe a diminution of the gain on the left superior semicircular canal. And the surprise was when we performed the myogenic evocate cervical potentials with a, as you can observe here, an threshold at 60 decibels. So there was, which is for us the the radar to detect some third windows anomaly. Of course, we perform TDM, high sensibility TDM, and we can observe effectively the presence of a large and very nice superior semicircular canal dehiscence. In other words, for the we already discussed the superior semicircular canal BPPV exists. We tried so to position it, and after 5 or 6 maneuver, we didn't reach to relieve the patient. The nystagmus was there with the same characteristics, and when we saw that, and when we found that maybe when we have the confirmation that a superior semicircular canal dehiscence was present, we ask ourselves that we have, if you have no, we can assist, we can if we are not in front of a case, a rare case of BPPV of the parasemicircular canal with the dehiscence associated, and we ask ourselves that if maybe a deformation of the superior semicircular canal would not explain the this typically BPPV of the superior semicircular canal, which didn't respond to normal physiotherapic maneuver. So what in this case, what you could, what may we use as another exam? We can prescribe what exam in your experience to have to have a physiopathological explanation.
I mean, when we do the ditch hole pike, let's say on the right side, you actually actually four canals at the same time. On the right side, you're stimulating the horizontal canal and the posterior canal. And at the same time, you're stimulating the left horizontal canal and the left superior canal. And it's the way you look at eye movements really is the way you would be able to figure out which canal. Of course, if it's horizontal, we know it's horizontal. If it is the right posterior, then you would get the rotatory component with the fast phase beating towards the downmost ear.
Yeah.
Okay. And vice versa. The other thing is, and I'm sure we all have done that, the VEMP is, to me, when you look at the X-rays alone without the VEMP, then that could be misleading. Because I have seen cases where you can see dehiscence and people coming to me saying, oh, we have been diagnosed with superior canal dehiscence. But in fact, because of the negative VEMP, that is not an active, shall we say, superior canal dehiscence. I don't know what your experience, Jerry, about that.
Sure. So you know, I find it seems to me there's a critical size that where you get smaller than that, you don't see the vents very prominently, and it's about 3 millimeters. If it's bigger than 3 millimeters, you tend to get more progressively abnormal vents, and in particular C vents. Personally, in our lab, I find OVEMPs are much more sensitive for picking up dehiscence than
Yeah.
CVEMPs. You know, I'm sure it's probably a little different in everybody else's labs, but there's a lot of times I'll find where the VEMPs, the CVEMPs look pretty normal, but the OVEMPs are very abnormal. And I don't usually see it the other way around, though. But I think if you look back when the original study that came out on CVEMPs as a means for detecting superior canal dehiscence, it came out of Dennis Poe's practice. And I know you guys, most of you guys know Dennis, and Dennis's main area of interest is patchless eustachian tubes. And I think what happened was he had a very select population that came in that had really bad autophony. And you think about it, if you have bad enough autophony, you know, sometimes it's from superior canal dehiscence. So I think if you looked at the patient population, you know, if someone's got bad autophony, they're more likely to have an abnormal CVEMP. But I don't think that necessarily correlates with somebody who's got more pure vestibular symptoms.
Okay, thank you for your observation. However, I thought I was very interested in when knowing that in our department we have a very good collaboration with our radiologist. I perform an imagery of the labyrinth and structures because I think that I thought at that very moment that it might be a little bit deformation of the superior semicircular canal, and as we know that an autoplugging phenomena may occur, I ask this three-dimensional high-resolution MRI, and I was very glad when I see the imaging because they are very interesting in fusion, but in 3D, as you can observe here. And our radiologist put some arrows here, but I think that the superior semicircular canal, it's here it's narrowed for more than 0.5 millimeters. And I thought, bingo, I think that I found why this person had a BPPV with no reductions of the symptoms with the maneuver. And I was very glad because told to myself that I think that I have the unique case with imagery demonstrating that processes of autoplugging could occur in this pathology. You know all guys that there was some papers which emphasize that we can observe some autoplugging process, but there was never published a similar case. And I will show you at the end of the presentation that I performed as research with ChatGPT to see what he think about it. So you may imagine with this slide that in case of you may try many maneuvers, and if since the otholites could agglutinate it a little bit, that maybe the particles which are inferior to we know that the particles could attain 30 microns, but if they are agglutinated, maybe with these things I think that was Perns which demonstrates that the otoliths could agglutinate and will create a gelatinous mass which will not obey to the gravity as we usually think. So imagine that particles, you try to put it in another, I should spin the image in the other side in the other direction to simulate a maneuver. But anyway, you will observe that it was difficult to progress some otoliths at a bigger dimension. So anyway, sorry.
Can I make a comment about that last slide just real quick?
Yeah,
You know,
please.
I think it's a beautiful slide. It's demonstrating a structural abnormality that we don't think about when we're treating BPPV, but I think it's a real phenomenon. The other thing, though, is even though this is a beautiful picture, it is a snapshot in time. You know,
Okay.
inevitably the dura is pulsating, and it's
Yeah.
probably plugging it up even more at times and less at other times. And I would think, you think about it, let's say you go to do a repositioning for anterior canal BPPV here, and you lay them back, you're going to be increasing intracranial space and causing further plugging, hence preventing the crystals from coming through that block.
Or
So
deformation of the superior semicircular canal.
yeah.
Yeah.
So if anything, you know, it's how do you get the crystals through without having the patient upside down? You see what I'm saying?
This is a very good point, Jerry and Eugen. What makes you think that the nystagmus we looked at is actually typical BPPV or BPPN?
It'd be hard to prove. I think you'd have to
No,
go.
I mean, I think it is an
surgically.
abnormal stimulation of the superior canal, and therefore the maneuvers will not work for it.
Yeah. I had, I will tell you, in support of Eugene's case, I had a patient who I did, and when I do superior canal dehiscence surgery, I don't plug. I'll put a piece of bone over the dehiscence site, and I used to seal it around with bone cement. Now I seal around with silastic sheeting, but this particular patient I sealed around with bone cement. She got a phenomenal result. All of her symptoms went away except for one new symptom that appeared, anterior canal BPPV.
Yeah.
And in retrospect, I think what happened was when I repaired the canal, I narrowed the canal. And we eventually got her BPPV to resolve, but only after about 6 months of a lot of head vibration and doing repeated maneuvers. But it took about 6 months to make it go away. But it was very reproducible. I would put her in the Omniax chair and check her
Yeah.
in that same exact spot every single time. And but we eventually got it out. But I think it was surgically induced narrowing of the anterior canal that led to a similar phenomenon to what Eugene's talking about here. So I do think this is certainly possible. Now, proving it is, a little bit more difficult.
Yeah.
Yeah.
It's difficult to prove. I agree. So in this case,
So, Eugene, you didn't answer my question. Do you think that was a paroxysmal benign position in the nystagmus?
yes, I think that in this case we have the elements, sufficient element to point the superior semicircular canal pathological biotoliths.
How about abnormal stimulation? And it's like either post-head shake nystagmus or spontaneous nystagmus in the plane of the superior canal.
I agree with your commentary, but there was typically the nystagmus had a latency. It was downbeating and to the left inner ear, torsional a little bit, and it was epuisable. It was not, it not, and was sensible to the eye fixation
Okay.
when repeated.
I'd
And
like to amplify most comments. I mean, you've got to be wary if you have a quote atypical BPPV. Maybe it's something else masquerading as BPV. Did this does this patient maybe had an anatomical abnormality which was long-standing and then had an event which caused them to be symptomatic, like a whiplash injury or an acute event? So really, you're seeing positional nystagmus as a sort of a non or a poorly compensated subtle vestibular disorder. Is that possible? And I'll tell you, you've got beautiful anatomical evidence there. But is that possible?
Yes, it is possible.
I think I also think that because everybody, all neurologists which are interested in the VPPV and we are all involved, we observe in normal peoples that in a supine position we can observe an nystagmus which occurs
Nystagmus. Yeah.
and no vertigo, absolutely no vertigo. But
Was this patient symptomatic when you put them in the
no.
position when you saw the nystagmus?
No. And there
Huh.
are some articles published recently by the Norwegians, I think, and Norwegian authors, which made with a large and a normal population with no autologic problems, with no neurological problems, with no migraine, that there are 6 on 10 patients, subjects, that may develop an nystagmus downbeating or lateral, even lateral, but more
Yeah.
frequently on downbeating nystagmus, which is not pathological. So I observe even in the recommendation of the French Society of Neurology, we don't speak about this aspect, and it's very important. But to come back to this case, we had all the condition to think that that was, however, an BPPV, maybe a little bit atypical because not reversal nystagmus, but there was they respected the law of the vestibular captor. The nystagmus respected also the gravity laws and was latency. That's for me was,
Yeah.
however, a very semicircular canal BPPV, even if the not a typical form.
Yeah, but
one other
we
point.
can call it actually a spontaneous nystagmus coming from the superior canal. Every
But
canal can generate post-head shake
Yeah.
and spontaneous nystagmus.
yeah, but she had a very important vertigo. All the clinical signs was uh,
Okay.
formal for a very, very impressive subjective reaction. But I will come back because it's interesting, the slides. May I continue? You have some other questions
I,
to
I
this
was just
point.
I was just going to mention, I think Art's comments are very important. You got to consider other etiologies, and in particular, whenever I see downbeat nystagmus, I'm thinking you got to make sure there's not a central phenomenon going on.
Yeah.
Yeah,
But I think the
good.
characteristics that you presented, it does not look central at all to me. I mean, it
Yeah,
looks like
No,
a
no.
typical peripheral positional nystagmus. In my case, is it BPPV versus just the pressure effect? But I would certainly lean much more toward the BPPV as opposed to the pressure effect. That said, another thing Art mentioned about trauma, trauma is heavily linked as a cause for anterior canal BPPV. And I think, having a superior canal dehiscence predisposes someone to getting BPPV in that particular ear.
Yeah.
I wouldn't be
mhm,
surprised if you check this lady at other times, she might have, some
yeah,
posterior canal and horizontal canal variants in addition to the anterior canal. I know you probably only saw her a handful of times, but, I would be kind of curious about that.
yeah. It's will come with this with the next slides. So, what do you propose? What do you suggest as a treatment in this case?
Go ahead, Jerry. I'll come next to you.
Okay. Well, of course, you see somebody with a superior canal dehiscence, the knee-jerk reaction is, well, let's go ahead and fix the dehiscence. But this lady has no other complaints. So I would be very
Yeah.
hard pressed to recommend surgery for the dehiscence, especially knowing that she really just has the BPPV as her complaint, and the I probably would treat her medically for superior canal dehiscence to try and lower ICP to kind of help
Okay,
prevent the
okay.
obstruction. And then I'd probably put her on home vibration to try and
Mm,
break those crystals up into
mm,
smaller pieces to help facilitate their movement with the repositioning.
I
okay,
will add also put a PA tube in the office as well. I would
okay.
do that.
And art, because you already art. What do you think? What you propose in this?
Oh, well, first of all, this patient is only subtly symptomatic. So as Jerry said, you can offer her surgery. Said, I might be able to fix your BPV. There's a chance I can. Do you want the operation? Secondly, she does have some kind of otolithic history or otolithic problem. It is important to have her keep as active as she possibly can and tell her, even if you have this BPPV, you're not causing any further damage. Don't worry about it. Keep as
Okay.
active as you possibly can.
And
Excellent.
She
you guys,
That's what I would tell her.
yes,
she
you,
doesn't have history of migraine either.
no, no, never, never, nor migraine, no other particular pathology, no vertigo in the normal day. Spontaneous or even evoked by pressure in the ears, by sound, nothing.
Okay, so
Okay. I'm
to
glad
you
I'm
and
glad the
to
patient
you,
said that. I made that comment before I saw the rest of your slide, Eugene. So I'm glad the patient
Yeah,
agreed.
yes, very well done, Art. So,
how, how do
as
we explain her hearing loss?
as exactly, there was no plant, except of course this this vertigo on of the right side, but with the exercise of Darrow, excuse me, type exercises, she was very glad. She was glad. It was very glad that there was an explanation. It's very important. I
Oh,
think that
Yeah.
when I explained to her that there is an particular
Yeah.
anatomical particularity which explain why this vertigo, I don't hear about her even 2 years after. I told her if something occurs, if there's something I explained what is the third, what means superior semicircular distance, and I averted her if in case of aggravation or operation of other symptoms came back to see me. So it wasn't the case. So of course, when I saw, I discussed with you, Gerard and Mo, that I will present this case. I called the patient and I saw her now recently, and I think I don't showed you these details. So um, here is the patient now in the Dixar pike position. She
mhm.
explained to me that from time to time she had some vertigo, but not so intense. And when you see the note, there was no nystagmus spontaneous nystagmus, and of course in the and
Mhm.
left Dixar alpine position, no nystagmus.
Aye.
More, and this is more important, not the reversal, no nystagmus, of course, and
Right
loud
side.
on the right side.
Huh?
And I was surprised because I expected to see again something, but nothing happens. So I was curious because now I have some cases with a typical clinical presentation with confirmed by imagery superior semicircular canal distance and with MRI which shows I must have now 12 cases of partial autoplugged spontaneously patients. And I asked myself, and here are and I asked myself if this process is not progressively, as you emphasized, Gerard. We must see these processes in evolution eventually, and it will be very interesting to observe that this spontaneous auto-plugging processes may occur in patient with an atypical clinical presentation. But you see this, as you can see here, the DHE was very low. She was have no complaints, and of course, the she is now 76 years old, and as you see, the threshold here of the cervical VAMS remains low. But because you told me, Gerard, I am perfect in accord with you when you perform the ocular VAMs. But ocular VAMs, as you know, start with 17 years old. They are not so they disappeared. So in this case also, I don't think that I have
Yeah.
OVMs here, but I perform it and was absent both sides. And instead, we can observe a little deterioration of the accentuation of the audiometric ring, but good intelligibility. And what I was surprised,
Oh, wow.
even this time, I perform not so many acquisition, but with a higher speed. She was a very sensible cervical junction, so I didn't perform many acquisition. But as you can observe here, the gains were quasi normal.
Her
Okay.
hearing has improved a little bit.
Yes, the hearing loss but she's 4 years older at the same time. And
Not
the
lower the low frequency.
otoscopy didn't show anything important. And I have now here the stapedian reflex. It was present to both sides. And of course, I was curious and I performed another labyrinthine MRI to see if I would like to have your explanation that will be the and I think that you have here the right side, the right labyrinthine structure, the anterior, and the left. And I think that is a little bit thinner. I have no still I have no the measure of my radiologist. I wait for her, but I think that the it's a little evolution. But I will tell you this the next time. If I think that it's a little bit more plugged, auto plugged. So some something about I found some in the literature. I searched for an explanation about the auto plugging. So as you know, the spontaneous auto plugging occurs to several possible mechanisms. I should add here possible. Tissue responses, body natural healing response can lead to formation of granulation tissue or fibrosis, inflammatory process, and some perturbations of the fluid dynamics, including higher pressure, intracranial pressure. But this patient didn't have any complaint, didn't have any signs of radiologic sign of intracranial hyperpressure. But we may think that this could play a role in these processes. And
Eugene, could you go
yeah,
back to the other slide for a second?
this
So,
one,
no, the next one.
yeah,
All right, so you have down here tissue response. The body's natural healing response can lead to formation of granulation tissue or fibrosis. Is that a theory, or has that been something that's been observed and published?
no, it's more like a theory.
Theory.
It's
Okay.
it's a theory.
I
So
was going to
that's
say
why
if
I
it's
said
been published.
maybe you. Yeah, no, it's a theory.
Okay, I was going to say if
And
it's been published, I'd love to see that. That would be fascinating.
Yeah.
yeah, and also the last point is really very important, the alterations in the endolymphatic pressure in the canal. So
Yeah.
the pseudo Meniere's in this canal.
Yes, because
Yeah.
we must take in consideration that the resistance of the vestibular membrane is not the same
Yeah,
along the vestibular structure. Besides, the auto-plugging process will change some points of
yeah,
resistance in the endolymphatic system.
sure.
You know,
It's very possible.
the other thing that I would point out is, you've got a patient 76 years old, and I know Eugene, that the dura of a 76-year-old is very different than the dura of a
Yeah.
20-year-old. And
Yeah.
some of these folks, at least surgically, when you get in there, the dura is so thin and flat and pliable that I think it lends to more prolapse into a dehiscence than somebody who's much younger. So I think the whole concept of auto plugging, in my mind, makes more sense in the older population versus the younger population.
Yes, it's very possible.
Mm.
And I think that I have more patient with this kind of imagine with start when a debut of auto plugging in person which have more than 50 years old.
Mm.
So yes, it's very possible. Yes, it's the very, the first imaging, the first articles with reporting some incomplete plugging was published in 2006 60s. And there are many other publications with this technique, but so I have this question because we start already to discuss. So I have did you have a explanation why this patient became? No, I will say no. No, I will not say that is completely asymptomatic. But how we can explain the disappearance of this BPPV now?
Yeah, I think
She,
it's probably migration of the otoconia. It's again, I go back to the images you present are just beautiful, but again, they're snapshots in time, and it's almost sort of like if you did this scan, 10 seconds later, you might see more or less deformation of the canal, depending on the pulsations of the dura or what have you. And I suspect at some point those crystals migrated through when the opening got a little bigger and then it closed and it didn't come back. Uh,
Yeah,
I guess the other potential explanation is maybe you've got more persistent plugging, but again, I go back to it's not a static phenomenon to where I think the only way it gets better is if the crystals get out.
yeah,
My
agree.
my my also explanation, which I have no way of proving it, that she really had, because of the dehiscence, irritative lesion into the canal that led to atypical, we can agree it's atypical BPPVN, and that disappeared after you plugged the canal. So
yeah.
you're following what I'm saying, Eugen?
Yes, and I see. My theory was that maybe the autoplugging process continued, and there was some particles with entrapped, but we can see some normal images here. There is a signal of the labyrinthine structure which appears as normal. But even in MRI, the ortholiths, they are not opaque to the MRI. So I thought that, but when I saw the normalization of the VHET, even to the high speed, I think that maybe the ortholith migrated effectively because it was an auto plugin normally and this age and in a subject of this age it would be expect to have an amputation of the gain to the superior semicircular of the left superior semicircular canal.
I really like your auto plugging theory. I mean, that's from a physiological point of view, it makes absolute sense. Having said that, the fact that her V hit is now virtually normal, there's obviously you can tell the patient there's something happened to you. Your brain has done a good job of
Yeah,
coping with that and compensating, whatever it was. One other point I wanted to make, Jerry was talking before about VEMPs and OVEMPs. OVEMPs are quite often successful, even in older people, in getting good results. And I've seen it in the literature. Don't ask me to send the papers. I can't remember where it was. I think it might have been Ian Courtois' paper. He said if you can only do one thing to try and find out about superior canal dehiscence, do OVEMPs because you'll see a massive, massive response. Some people in CVEMPs have a subtle subthreshold response for like whatever reason, but OVEMPs are usually extremely high and in acute or in acute or dehiscence syndromes, even if they're acute, even if they're non-acute, but just becoming present, presenting. So from the audiologist point of view, if there's a bunch of diagnosticians here today, if you can only do one thing, do OVEMPs.
yeah, I agree, Art. But in this case, effectively, this patient, she didn't at the last assessment, there was no
Right.
CVMs at the
Yeah. Yeah.
examination.
Yeah, that's a shame. That's a shame.
The other thing, the absence of the ovamps, implies utricular dysfunction, which implies maybe the otoconia got knocked loose, which led to the BPPV to begin with. But I
Yeah.
want to make one other comment that you mentioned where after you explained this to the patient, she was very happy, even though she was no better and she was still having her vertigo spells. And I think that's a real important point, that there's a lot of folks that I see that once you explain to them what's going on, a lot of times the treatment becomes not nearly as important as just to reinforce that they're not crazy and that there's a
Yeah,
reason for their problem.
exactly.
It's not going to kill. And
Jerry, she continues to have hearing loss with more conductive even component post-operatively. And she probably will continue to have some, I'm going to kind of phrase it carefully here, endolymphatic imbalance in that canal.
it would be interesting to see what an
I mean,
MRI with inter-ear hydrops protocol would look on this lady.
I would, and next time she comes to see you and she's having any symptoms related to the canal, I would put some dexamethasone in her ear.
Okay,
Okay.
but when I asked for this MRI, I demanded also sequences for eye drops, and it was negative.
Okay. All right.
I
Okay.
don't, unfortunately, I don't prepare the images, but it was negative. Okay, so
So
this
how
was
do we explain the hearing loss, Jerry?
Uh,
sorry.
he was asking, how do we explain the hearing loss? I think you've got
Ah,
a third window syndrome and you're losing acoustic energy, that's getting diverted over toward the labyrinth as opposed to the cochlea. I think that's the most likely explanation for the hearing loss.
yes, but she remains only. It was only the transmissional hearing loss. She didn't have autophonia. She didn't. There were. She was not at all bothered for the other cortege of symptoms of the third window syndrome.
Yeah, which kind of goes back to, if she's not complaining it and she's happy with it, I don't know if I would
That's what
very
counts,
aggressive.
yes.
Yeah.
Huh.
So this is the last slide, and I told you that I put the question to the ChatGPT, and he confirmed that was the very first image in published with this famous auto-plugging process. But there are many others person which are interested in this evolution. It might be a way to better understand this mechanism of the third mobile window. There are so many other uh, things we don't know about it. And I will challenge guys to maybe to get a paper together these topics. And I ask also to Andrea Castellucci because he's very interested in these topics. He published at least two articles in these topics, and I think it's an important way. It's a way to explore and the understanding of this challenging pathology. I thank you very much for your attention.
Excellent case.
It's a fascinating
Yeah.
case.
Yeah, that's great.
Well, are there any other questions out there? Anybody else want to chime in?
You need to check the chat.
Yeah, I had a question. Thank you so much for that presentation, Dr. Eugen. That was fascinating. My name's Kayla. I'm a physical therapist located in Seattle, and I specialize in vestibular rehabilitation. And I occasionally see anterior canal. And I just wanted to make sure I was understanding correctly that if the nystagmus that was occurring in the Dix-Hallpike is not driven by positional vertigo, but more driven by pressure changes, when you put them back into the Dix-Hallpike, is it changes in the cerebral spinal fluid? Is it venous? Is it arterial? What is pathophysiologically increasing the pressure in the superior canal?
All of
When
the above.
It
yeah,
is all okay.
Who knows?
Okay. So it could be one of those factors. Have you found any distinguishing factors between being able to determine if it's more of a pressure change versus positional vertigo? Like you had mentioned latency, if there's a latency or there's a reversal, obviously that's more consistent with a positional vertigo or a BPPV versus a pressure change. Have you noticed any other different characteristics and how the nystagmus presents that could help you potentially determine if it's BPPV or it's a pressure change?
no, actually, in fact, what is important, yes, I saw some positional nystagmus in patient with hydrops and Meniere disease or secondary hydrops, but there are not the classical signs for a BPPV. So when it's a PPPV, we must have the latency, we have the sense of the nystagmus, and normally the nystagmus will stop after 30, 40, 50 seconds. It depends. But we can have some, as I affirmed here previously, there are normal subjects which have a nystagmus, downbeat in nystagmus, with not at all complaints. So we must put us ourselves the question: did we really well examine our patient? Because some normal patient may have a nystagmus which is difficult to explain with no pathology. So the message which is important, in my opinion, to transmit it to the physiotherapists and to the other, to the medicine, to the ENT, that there are subjects with normal nystagmus, normal, with no symptoms. And in this case, imagine what could happen in these subjects which could experience anhydrops or a real VPPB. We can imagine that the nystagmus we will observe, it's a resultant between the normal nystagmus they have had before, excuse me, before the neurological phenomenon and the nystagmus generated by this pathology. I think that it's a little bit.
Yeah.
I would add one other thing, a distinction between BPPV versus positional vertigo from a dehiscence, particularly superior canal dehiscence. It's one distinction is when you put the head down, whether it's to the left or the right, you're going to get the same nystagmus with a superior canal dehiscence, whereas with BPPV, it's going to be different.
Right.
Yeah.
Right. Okay. Yeah, I was looking for like a clinical distinction to kind of help tease that out.
The other thing is, whenever you see nystagmus in the clinic during Dix-Hallpike or during the entire vestibular exam, we really need to know that it is a sign. It's not a diagnosis. We cannot just say it's vertigo. We have to find out what is going on in the ear, because people with Meniere's disease, people with vestibular neuronitis, people with migraine, post-trauma, there's a lot of underlying that can lead to, say, same type of post-head shake nystagmus, but it's our clinical duties to find out really the best possible explanation. And sometimes we don't find the answer, and the patients get better, which is helpful.
Yeah.
All right. Any other
Oh, that's
questions
great.
out there? We're just about at our time's up at an hour. Does anybody else have any final comments or questions? Eugene, anything else you want to add?
No, only the fact that you told it, and effectively when I didn't thought this. Yes, when you have a large distance, effectively the traction exert by um, dura on the vestibular on the membrane of the superior semicircular canal will generate some tractions, or by the gravity in the up position would generate the same nystagmus. I perfectly agree with you, Gerard.
And Mo, any other comments from you?
Yeah, I actually, every time we talk about BPPV, I have to go back to what Eugene Mira did in his animal experiment. I think if BPPV is not the typical, we really should get the ionized calcium and the PTH, because I have seen patients who have abnormal calcium homeostasis and benign positional vertigo.
But in any event, I'm going to close things out because we're past our hour. And just to kind of let everybody know, our next conference is going to be on Friday, July 11th. And I'm going to be presenting a surgical cure for vestibular migraine. And that's a little teaser to get everybody interested to come back and see. Anyway, I'm gonna close things out, and thanks again for everybody joining in. Hope to see you next month.